So good morning. We're glad to have you all here. I think you're in for a wonderful morning, and there's lots of things to do and see and hear. So we want to make sure we get all of that in, and you guys can also visit the fair and all the tables. There's lots of testing you can have done, and so I'm sure you'll want to be able to do that as well. So a couple of announcements. The way we're going to do this morning is that we have 3 speakers, and then we'll do question and answer. And so if you have questions during this time, what we want you to do is write them down. You should have paper and pen in your bags, and then you're going to pass them toward the wall to the end, and we'll pick them up, and then we'll run through your questions up here at the end of the session. And I should tell you, I'm Jennifer Tremmel. I didn't say who I was. So I'm Jennifer Tremmel, and I run the Women's Heart Health Program. And you're in the Women's Heart Health session. And if you didn't mean to be here, then this is your moment to get up and go somewhere else. And I have wonderful speakers with me. So Dr. Abha Khandelwal is here with me, and Dr. Sandra Tsai. And these are both women that are part of our team. So this is our Women's Heart Health team. Women's Heart Health at Stanford's been around since 2007. We have, in addition to Dr. Tsai and Khandelwal that you see up there, my nurse practitioner, Mary Najudli. She's out at a table, and you'll meet her today. Dr. Edwards is our psychologist, and then Dr. Shirley Park and Dr. Vanita Chandra are electrophysiologists and vascular surgeon who also help us out. So we actually have a very large team that helps specifically with women and understands the differences between women and men. And this is one of, if not the largest, women's heart health program in the country. So why do we even need a women's heart health program? So some statistics, if you don't know, this is the leading cause of death in women as well as men in the United States. 1 in 4 deaths that women will have are attributable to coronary artery disease, and 1 in 2 to all forms of cardiovascular disease. So that means half of the women in this room will die from cardiovascular disease. Heart disease isn't just an older woman's disease either. It's the 2nd leading cause of death for women aged 45 to 64, and also the 3rd leading cause of death for women aged 25 to 44. Cardiovascular disease kills more than 500,000 women per year, and it kills 6 times as many women as breast cancer. And so there's always a big focus on breast cancer, but heart disease is actually every woman's greatest threat. And in fact, it kills twice as many women as all forms of cancer combined. So these statistics aren't certainly what we want to hear. The other thing is that more women have died of cardiovascular disease than men since 1984. Fortunately, these cardiovascular deaths are going down, as you can see, and actually this gap that we see between women and men is narrowing, and that's a good thing. So when we used to give talks, we had this big gap where this is death in women and this is in men. You can see that's getting smaller and also going down. So there is hope. There's also, you're going to have a prevention session today, so we encourage you to go to that and understand prevention as well. So the one place where we're not seeing an improvement between the sexes is dying from heart attacks. So women basically have twice the chance of death with a heart attack compared to men, and this has been fairly consistent over time. And there's lots of reasons that we think that this is the case. Some of it is kind of an under-awareness on women's part. What are the symptoms? Not really recognizing their own risk. And then some of it is when you come in, physicians actually not necessarily acknowledging your risk and moving as quickly as they should. These things, I think, are all improving, but we have a long ways to go. So I wanted to briefly go over what are the symptoms that you need to watch for. And some sort of chest discomfort is the most common symptom. This is the most common symptom is in men as well as women. Women are less likely to have it than men, but that's still the most prominent thing that they will feel. And this discomfort can be a pressure, a tightness, an aching, so it comes in a lot of different feelings. And it also may go down the arm. It could go down either arm. It's not just the left arm. It can go up into the jaw. That's particularly common with women, and it can go into the back. There may also be shortness of breath. For some women, shortness of breath may be the only thing that they have. Fatigue is also a big one. You can feel sweaty, nausea, vomiting, lightheaded, or faint. So those are all symptoms that one would be concerned about that they might be having a heart problem. So I wanted to show you a little video that you might have seen. It's been out for a while, but this kind of demonstrates the symptoms and maybe some of the reasons why women aren't always getting to the hospital as soon as they should.
It started out like a totally normal day. Mom! Okay, move objection deadline to the third line after survey. Oh, honey, for when you always use the verb start. What are you doing down there? Did you finish your breakfast? Ow. Don't hit your brother. Honey, you have to eat something. Here. Okay, 5 minutes to carpool. Where's my coffee?
You okay, Mom?
Oh, I'm fine. Sandwich orders. What do you want?
Almond butter and jelly.
Spaghetti.
You sure you're okay?
I'm fine, sweetie.
I am so late. Hey, buddy, how you doing? Hey, honey. You okay?
Yeah, I'm fine.
You sure?
Oh, yeah. Here.
Acai, my favorite. See you guys later.
Wear your shoes. Put your shoes back on, please. You know, go help your sister. We're going in 3 minutes. Oh, my God, what am I doing? I forgot to cut off the crust. Voila. Shoes on, potty if you need it. Honey, get your sister. Okay, here. Nobody move. I'm getting a dustpan.
Mom! I think you're having a heart attack.
Honey, do I look like the type of person who has a heart attack? I'm just gonna sit down. I'm totally fine. Don't forget to wear the high socks with the shin guards.
Forget about the shin guards, Mom.
Come on, Mrs. Underdog is not gonna wait. Whoa. Okay. 9, 1, 1. Hi, sorry to bother you. I think I might be having a little heart attack. Nothing really, just some nausea, tightening of the jaw, dizziness, shortness of breath, muscle pain, achiness, this terrible pressure in my chest. Oh, really? They can be here in how long? 2 minutes. Can you make it 10? I thought I had gas. Turns out I was having a heart attack. Heart disease is the #1 killer of American women. So now I take care of my heart and I tell the women in my life to do the same.
Sounds great, by the way.
That's nice, sweetie, but that's not my heart. That is. Make it your mission to save your life and the lives of the women you love. Find out more from the American Heart Association at goredforwomen.org.
Okay, so I think that's a nice video. It really demonstrates kind of what some of the symptoms are, and also that we can't really stereotype who's having a heart attack. You know, we think we can look at someone and say, that looks like a person that's gonna have a heart attack, but we actually don't always know. So a lot of what I'm gonna talk about today are different things that can cause chest pain in women, and there's actually a whole host of them, so we'll kind of run through. It's not always just a heart attack. So let's start with this. This is a little depiction of a plaque that's building up. This is from the inside of the artery. So you can see this would happen slowly over time, that you would have buildup of plaque. It has cholesterol inside of it. And then one day this can suddenly rupture. And so then the contents inside of it will be exposed to the bloodstream, and the blood will start sticking there and make a clot. And that ultimately will close off the artery. So that's kind of what a heart attack looks like from the inside of an artery. This is what it looks like in the cath lab. That's where I work. And what we do is we take pictures of heart arteries and fix them. And so on this side, you see that there's just this is a catheter, and there's a little bit of blood that goes in and it stops. And really the artery should look like this, So this is where that clot formed, and it's making it so there's absolutely no blood flow at all to this side of the heart. And if we didn't open this up, then this territory will simply die over the next few days, and it won't ever come back. And so what we do is that we open this up and restore blood flow. So this is after we've opened this up and put in a stent, that the person now has all this blood flow to this territory. And we try to do that as fast as possible. So that's the kind of classic heart attack that we think about, but actually not all heart attacks are from plaque, and particularly in women. Women can have other causes that aren't quite as well known. So I'm going to talk about coronary spasm, coronary dissection, and Takotsubo, which is in the lay press has been called broken heart syndrome, and you might have heard about that. These things can also occur in men, but it's much more likely that they're going to occur in a woman. So coronary spasm, so this is where the artery basically just clamps down in one spot. Women seem to be a little bit more vasoreactive, and some women, for not totally clear reasons, can have arteries that will constrict. This may be related also to things like migraine, or people that have what's called Raynaud's, where they don't get good blood flow to their fingers when they get cold. And so if this constricts and it basically blocks the blood flow, it's exactly the same as if you had that plaque with a clot in it and there's no blood flow getting through. One way we diagnose this is you may go to the cath lab like you're having a heart attack, and we see these narrowings, and there's actually a narrowing here, and then this blood vessel doesn't even have any flow, and then we give a medicine called nitroglycerin, which dilates the vessel, and suddenly all this goes away. And so that's different than a plaque. This is coronary spasm. Coronary dissection is another thing that we see in women. It's unfortunately, I think, missed a lot by physicians. This often occurs in women who are young and have no cardiac risk factors. And what happens is that the artery has multiple layers to it. And for, again, kind of unclear reasons, maybe related to hormonal changes, the layers will suddenly split. And so when the layers split, the blood then goes back behind the wall instead of down through the true lumen here that it should. And when it goes behind the wall, it basically will compress the lumen so that you're not getting blood flow through there. So this is an example of it, and I hope it will, you'll be able to kind of see it. But if you come here, this artery should keep going down through here, and you can kind of see a trickle of blood flow going down through there. But basically this whole vessel from here on has split and is not getting good blood flow. Oftentimes this will tack itself back up, but sometimes it's actually very hard to fix this, and women can have a full heart attack in this area if we can't get the blood flow back. And then there's this, this entity called Takotsubo, which is broken heart syndrome. And this is another condition where women will come in and it looks like they're having a heart attack. They're having all the same symptoms. But then when we go to the cath lab, their arteries are perfectly fine and open. And what we find out is that their heart's actually not pumping well. And so the heart, when it pumps well, this is the main pumping chamber. Here it is relaxing, and then here it is pumping, and it basically squeezes, and it squeezes all the blood out. When you have Takotsubo, you get this funny configuration where it squeezes up here, but it actually balloons out down here. And the word Takotsubo is actually a Japanese word for octopus catcher. And so this is a pot that will catch octopus, and it's felt that this pot looks like how the heart looks when you have this. Takotsubo is more common in postmenopausal women, and it's often related to emotional stress. And so some emotional stressor, someone you love gets very sick or something like that. This is an acute reaction, maybe related to stress hormones, and suddenly the heart starts pumping in this way. Most women do okay, and this will resolve in about a week, but sometimes they have to be supported during that time so that they can recover fully. So when you have symptoms, not all of them are a heart attack, and in fact, more commonly, people have chronic symptoms. So a heart attack or the things that I just described happen acutely, but you may have your symptoms chronically. So angina is a word that we use for these kind of chest discomforts, and it's temporary and recurring. So it often comes on every time you exert yourself or with emotional stress, and it's from not getting enough blood flow to your heart. And sometimes angina can get worse over time. Say there's a blockage and it gets tighter and tighter, and you could finally have a heart attack from that. But oftentimes it will stay stable. And there's some people that live with having angina chronically through their lives. And certainly what we try to do is minimize that. More women than men have angina. And more women are likely to have angina without blockages. And again, we always think of plaque and blockages, but there's a whole group of people that their arteries look fine. And so one of the questions is, do they have something functional wrong with their arteries as opposed to the traditional plaque? So here's what it looks like just from the plaque buildup. This is the most common cause of angina. This is a woman that I took care of who was only having shortness of breath every time she went walking. It was a new problem, been going on a few months, and seemed to be getting worse. And so what you can see is there's this blockage right here. So she's basically got kind of a little passageway that the blood's getting down, but it's actually quite slow flow down here because this is so tight. This was about a 99% narrowing. It was actually very calcified, and to open this up, we even had to drill through this. And then we were able to open it up and put a stent in, which is a metal tube to keep it open. And so now you can see that that's fixed, and she feels great because her problem is now gone. So what about when there isn't a blockage like that? So one of the things that can happen is what's called endothelial dysfunction. So the cells that line the artery wall are called endothelial cells, and they're responsible for helping the vessel constrict or dilate at appropriate times. And when you have endothelial dysfunction, your artery actually does the opposite of what it's supposed to. So when you go to exercise or you're emotionally stressed, your artery should dilate so you get more blood flow to your heart. But in fact, people with endothelial dysfunction, their artery will constrict on them. So we can test for this. So this is a woman who, this is at baseline. Her arteries are nice and open, smooth, no blockages, looks perfectly normal. So then we give a medicine called acetylcholine. In a normal person, the artery would dilate, but you can see in comparing this to this that she has diffuse constriction through here. So you can see the artery gets smaller. So this is what's happening when she's exercising or emotionally stressed, and why she doesn't feel well. And so somebody like this, if we get this diagnosis, we can put them on vasodilators to help their artery dilate so that they feel better. Another thing that women can have where their arteries look perfectly normal is microvascular dysfunction, and this is where the small vessels don't work well. So all these pictures I'm showing you are the big vessels, and we can see those big vessels, but what about all these small vessels that come off the big vessels and ultimately feed the heart muscle? If those aren't working, then the blood goes down the big vessel, but it never really gets to the heart muscle. So there's actually special testing that we can do in the cath lab to diagnose that as well. And I won't explain that to you, but there is something that can be done in terms of testing. Oftentimes people are given this diagnosis, but nobody actually went and did the testing. And I think it's important to ultimately get a true diagnosis of what's going on. Another thing that we can see is called a myocardial bridging, and this is where the artery dives down in the heart muscle and then comes back out. The people that have this are born like this, and what happens is because the artery's in the heart muscle, it actually gets squeezed every time the heart beats. And this is very common. We think at least a third of the population has myocardial bridging, and it's actually not a big deal. So people will have it, they'll go through their whole lives, they'll never have symptoms from it. But there is a subset of people that do seem to get symptoms from getting their artery squeezed. And these symptoms usually show up in the 30s to 40s, although we've had some teenagers that have symptoms, and then we've had people in their 70s that are suddenly getting symptoms. So when we find this, there's also extra testing that we can do. So I will point out the bridging. Hopefully you'll be able to see it. So if you look right here, every time the heart beats, you can see the artery squeezes right in that spot. And out here, there's almost like a winking. So every time the heart beats, the vessel gets squeezed. And so the blood flow gets cut off during that time. And then spasm. So we talked about spasm before. So spasm can actually come in like a heart attack if it's totally blocked, but spasm can also just constrict it enough that you get some discomfort, and then it backs off. And this is a little different than the endothelial dysfunction because this is the smooth muscle cells that are constricting. And this is something that will come on suddenly out of the blue. So it's not necessarily with exertion or emotional stress. You're minding your own business and you suddenly get this discomfort. And this typically will be recurrent, usually a few times a year. Sometimes people have it much more often. It's most common in the early morning hours, 2 to 3 in the morning. You suddenly get this chest discomfort. Usually lasts about 5 to 10 minutes and then goes away. We often make this diagnosis simply based on the history. If it sounds like that, that's what it is. And we, again, give vasodilators to help relieve that. And a lot of women, once they get on a vasodilator, never have that chest discomfort again. So as a final little list, there are lots of things that can cause symptoms, again, and they're not actually all from the heart arteries either. So people can get what's called myocarditis, which is inflammation of the heart. They can get pericarditis, which is inflammation of the sac around the heart. Hypertrophic cardiomyopathy is a thickened heart, can cause same sorts of chest discomfort. Diastolic dysfunction, which you're going to hear about from Dr. Kandawal, is where the heart doesn't relax appropriately, and so when people exert themselves, pressure builds up and can cause shortness of breath and some discomfort. Aortic stenosis is a valve problem where the valve gets tight and the blood has a hard time getting out, and those people can get chest pain, shortness of breath, and even feel lightheaded. And then there are things that are even non-cardiac. So pulmonary embolus is a clot to the lungs. Pulmonary hypertension is buildup of pressure in the lungs. And then esophageal spasm, so it can even be GI things. So the point of all this is certainly to let you know that there are lots of things that can cause chest discomfort. All of them should be attended to. So if you are having symptoms, you should let your doctor know. Too often women don't go and seek help, or their doctors don't necessarily give them full credit for what's going on. So I would be persistent in saying, is there something wrong with my heart, and getting a full evaluation. And remember through all this that cardiovascular disease is our #1 killer, so we need to take good care of our hearts. So thank you for your attention, and we're going to move on. So Dr. Kandawal is going to do our next talk, and she's going to talk about the failing heart.
Okay, good morning. Thank you for coming. I'm going to talk to you a little bit about the failing heart, and specifically in women, how sometimes it's related to not having enough time to relax. So the actual definition of heart failure is a condition where the heart muscle is unable to pump enough blood to meet the demands the body has. This results in fluid retention, and the fluid retention can result in many, many different types of symptoms. Sometimes people can present with shortness of breath. They can present with swelling of their feet or legs. They can have a chronic lack of energy. Oftentimes they'll have difficulty sleeping due to difficulty breathing or coughing. They may need more pillows and are sleeping more upright. Over time, one can notice a swelling in their abdomen that will decrease their appetite, and they can also have a new cough that's associated with a frothy sputum. People may notice that they have increased urination more at night, and also one can note that they have more confusion or impaired memory as a result of poor perfusion over time. Heart failure is actually quite a big problem. About 5 million people in the US suffer from this condition. And depending on what studies you look at, anywhere between 400 to 700,000 cases are diagnosed annually. And in fact, if you look at all the different cardiac conditions, it's one of the few that's actually on the rise. And if you look at over the past decade, the annual number of hospital admissions has been from 800,000 to 1 million as the primary diagnosis. And if you include heart failure as a secondary diagnosis, this number has increased from 2.4 to 3.6 million hospital admissions. And we know that heart failure is more common as we get older. The incidence can approach about 1 per 100 patients, especially after the age of 65. In fact, more dollars are spent for the diagnosis and treatment of heart failure than any other diagnosis by Medicare. So this is an important problem. It's estimated that the annual cost is around $30 billion. Despite all of these resources being put into heart failure, the prognosis still is a little dismal. In fact, about half the patients that are diagnosed with it will die within 5 years. And if you compare the 1-year survival rates to some of the other conditions, you can see it's also pretty sad. If you look at AIDS, the 1-year survival rate is about 90%, and about 17,000 patients die annually. In leukemia, it's about 64% for 1-year survival, and only about 20,000 die annually. Lung cancer, the 1-year survival is 42%, and about 157,000 patients die annually from this. If you look at pancreatic cancer, the 1-year survival is 21%, and about 36,000 patients die from this annually. If you combine all of this, this makes about 230,000 patients that are dying from all of these conditions. If you look at someone with end-stage heart failure, even with our best medical treatment, their 1-year survival is 25%, and 30,000 more patients die than all of these other conditions combined. So what are the risk factors for heart failure? Well, the most common are coronary artery disease, which is a blockage in the arteries that supply the heart. The next most common is diabetes. It's often defined as a high blood sugar, greater than 126. High blood pressure can cause heart failure over time, and that's defined as a blood pressure greater than 140/90. Some other causes are obesity, which is, as we know, on the rise in this country, and that's defined as a BMI greater than 30. The BMI is an index of your height and your weight. Elevated cholesterol or aberrations in your cholesterol can put you at risk for heart failure, so a total cholesterol greater than 200. And then the specific subtypes of cholesterol, like the LDL, traditionally viewed as the bad cholesterol, greater than 100, or an HDL, traditionally viewed as the good cholesterol, less than 40, and triglycerides greater than 150. And I already mentioned that heart failure is more common as we get older. There are some types of heart failures that run in families. So if you have a family history of someone who's had heart failure, particularly at a younger age, you may be at risk. There are some abnormal heart rhythms that can also predispose you to heart failure. For instance, atrial fibrillation is one common one. If you're utilizing cigarettes or drinking excessively, this also has detrimental effects on the heart muscle, causing you to be at risk for heart failure. And then there are some more rare conditions. For instance, there are some congenital heart diseases or heart problems that patients are born with that can put them at risk for heart failure. The valves of the heart can sometimes not function properly because they're too leaky or not opening properly, and that can cause you to have heart failure. Some thyroid diseases, anemia, and some cancer treatments can also induce heart failure. And there are some unique heart failures that happen around the time of pregnancy. And then renal failure and some other autoimmune diseases are also implicated. So how can we avoid getting heart failure? Well, obviously it's to avoid obtaining those risk factors, but some of the other things we can do is to lead a healthy lifestyle. We encourage greater than 30 minutes of moderate intensity exercise daily, and if you're overweight, we state that this should be 60 minutes or more. If you're smoking, we encourage cessation. If you're overweight, we have a dietitian that helps with weight reduction, and we overall encourage a heart-healthy diet. Oftentimes, we like to try to treat a lot of these things with lifestyle and behavior modifications in our program. However, when needed, we also will treat with medications. How can one be diagnosed with heart failure? Well, in general, this is a clinical syndrome, and a lot of it can be diagnosed just based on history and physical exam. But sometimes physicians will also use advanced tests such as ultrasound of the heart, called echocardiography, or x-rays to look at fluid to see if there's buildup in the lungs. There are some advanced blood works that can also look for strain on the heart or pressure buildup in the heart. For example, there's one blood test called the NT-proBNP that we use to sometimes help us with the diagnosis. As Dr. Tremmel mentioned, there are certain types of heart failure where you feel the symptoms mostly when you're exerting yourself. The pressures are elevated when you're exerting yourself. So we can use special types of stress tests. These are not the same kind that diagnose heart attacks, but these are kinds that look at the oxygen utilization and also the pressures in the lungs to help diagnose it. And then in some cases, we will actually do invasive tests where we go into the heart itself and the lungs and measure the pressures directly with our catheters. So these are examples of ultrasound images that we use. We consider basically two types of heart failure that are on a spectrum, and we differentiate them based on something called the EF, or the ejection fraction. The ejection fraction is the percentage of blood that is ejected in the heart that is supplied to the body with each beat. So generally in a normal person, about 55 to 65% of that blood should be ejected. If you look on the right side here, this heart muscle is, take my word for it, a little bit thin, and it's dilated, so it's not strong enough to generate the force to pump out 55 to 65% of its blood volume with each beat. Therefore, we end up with fluid retention, and this is called heart failure with reduced EF. This is the traditional type of heart failure people think of when they talk about it. This is usually more common in men, and it's usually a result of either several heart attacks or coronary artery disease. But in women, we actually are a little bit more prone to this type of heart failure, which is called a heart failure with preserved EF. So as you can see here, the main pumping chamber, the muscle is actually very thick, and it's actually going to have no problem pumping 55 to 65% of its blood volume to the body. But as you can see, the cavity here is pretty small compared to this one, so it's actually not able to relax an amount of time given between each beat to fill properly, and it results in the same problem, which is fluid retention. So our therapies are often guided based on the stages of heart failure, and we have a system called the New York Heart Association class that we use to help stage patients with heart failure. So it starts with 1 and goes up to 4. The prognosis and the treatments get more intense as you go up this chain. But if you have New York Heart Association Class 1 heart failure, you actually have no limitation of your physical activities. You may have a structurally abnormal heart, but you're able to do everything you need to. If you move to stage 2, it's still considered fairly mild disease because you're not having symptoms with really, unless you're doing significant activity and you're able to carry out all your ordinary activities. By the time you get to stage 3, you're having symptoms with those ordinary activities and may even be limiting some of the activities you do because of these symptoms. However, by stage 3, when you rest, your symptoms go away. By the time you get to stage 4 heart disease or stage 4 New York Heart Association class, you're having symptoms even at rest, and any minimal activity is really exacerbating your symptoms. And this can very significantly affect your quality of life. And you can move between these. So for example, someone may normally be a New York Heart Association Class 2, and then for some reason they forgot to take their medications for a week or 2 and end up coming into the hospital with stage 3 or 4 heart failure. So in heart failure with reduced ejection fraction, that's the one where the heart muscle is not able to pump properly. We have a lot of very good studies done to look at different treatment options. So in those patients that are having a weak heart muscle because of a blockage in the arteries, we can open up those arteries like Dr. Tremmel does with either stents, or we can send them to our surgeons to do a coronary artery bypass and restore blood flow to the heart muscle to hopefully make it stronger. There are also certain medications that we use that can help make the heart muscle get stronger. For instance, there are drug classes known as beta blockers that help protect the heart muscle, or ACE inhibitors. In patients for symptomatic relief, we can also give medicines known as diuretics that help reduce the fluids in the system and help patients comply with a low sodium diet. That's considered about a 2 gram per day diet, which is a little bit less than a teaspoon. In patients that have abnormal heart rhythms, we can teach the heart with a special pacemaking device how to beat properly and over time get stronger. And in very severe cases, like I think some of you recognize with Mr. Cheney here, we can use mechanical devices to actually do the pumping of the heart for them, or potentially even in select candidates, give them a transplant. But with all of these therapies for heart failure with reduced EF, we've been seeing an improvement in the number of hospitalizations for these patients. However, in our patients that have the preserved ejection fraction, those hospitalization numbers have not changed. And in fact, when you look at the composition of male to females who are coming into the hospital, whatever study you look at, the yellow is women and the blue is men, it's consistently more women that are coming into the hospital with this type of heart failure. Most studies say anywhere between 50 and 60% are women. And this is just another ultrasound picture, again, showing the heart muscle is very thick. The cavity that it has to fill with the blood is very small. And this is a gross specimen of a heart, again, showing this is very little. This is obviously a very dramatic picture, but there's very little room for blood to fill to then be pumped in the future. As a result, we don't have as many great studies in this type of heart failure. So we do have some studies showing that we can improve quality of life and exercise capacity, but not necessarily improving length of life or mortality. One of the medicines we can use helps slow the heart rate down, giving it a little bit more time to fill, so giving it more time to relax and get blood into it. If you're having abnormal heart rhythms, for instance, like atrial fibrillation, we can help control those abnormal heart rhythms. In terms of symptomatic relief for the fluid retention, we can decrease it with diuretics. Again, they help you urinate out the extra fluid, or again, help you comply with a low-salt diet. And we also try to improve blood pressure control, which again will help you prevent getting this disease and with disease progression. There are also some studies looking at improving exercise tolerance, and I'll talk to you about that in the next slide. For patients that are overweight, we again have a very aggressive dietary program to help lose the weight and to decrease alcohol and smoking if you're utilizing those substances. There are a bunch of different studies looking at what type of exercise training is best. Probably the best data is looking at around a 12-week home-based regimen that is using moderate intensity aerobic exercise, and it's about 30-minute sessions, about 4 days a week. Once you're able to comply with this, then you can add low resistance 2 to 3 times a week for this. We know that exercise has direct benefit by decreasing that stiffness that happens with the heart muscle and the vasculature with age. And there are some studies showing there's first an initial short-term benefit within a couple hours, but then also a longer-term benefit that happens over the next week or so. But I guess the big point of this is that we actually need more research to have better, well-established therapies, because the paradigm that we're using for heart failure with reduced EF, we're seeing is not really working in the heart failure with preserved EF population. So if you think about it, 5 million Americans suffer from heart failure and get about $28 million of funding annually. So this is the heart failure population. This is the lung cancer population. Lung cancer has about 400,000 patients, and they get 132 million in research annually. So, you can think about that for a minute. And my last slide is just some resources. There are actually a lot of resources. I just listed a couple of the major ones where there's a lot of good facts and patient information for you if you would like to learn a little bit more about heart failure. And at this time, I'm going to hand the computer over to my colleague, Dr. Tsai, and she's going to talk to you about hormones. It'll be a little bit more uplifting.
So, hi, I'm going to be talking about menopausal hormone therapy, the who, what, when, and how. So we'll be talking about this in the context of a very typical patient. She's a 49-year-old woman. She is self-referred for possible estrogen therapy. She has hot flashes and difficulty sleeping for the past year, but the severity and frequency have increased recently, so she comes to you. She frequently wakes up, finds it difficult to concentrate, and has vaginal dryness. Her last period was 1 year ago. She tried soy supplements and black cohosh without any relief. She has no personal or family history of coronary heart disease, stroke, blood clots, or breast cancer. So this is a very typical patient. Menopause, on average, occurs by the age of 51. So she definitely falls within that range. We actually define the date of menopause as starting 1 year after your last menstrual period. She has very typical symptoms. She doesn't sleep well. She has hot flashes. She's difficult in concentrating. And she's definitely tried some non-hormone-based therapies, which are often very commonly tried, like black cohosh and soy supplements. So let's look at this patient while we're thinking about how a clinician might actually approach this patient. And just to give you a little bit of background information, prior to 2002, it was very common for women, postmenopausal women, to get hormone therapy to prevent heart disease. And in 2002, the Women's Heart Initiative findings came out and really turned all of that thinking on its head. So this was the largest clinical trial using hormone therapy. It was a landmark trial. They enrolled 27,000 women, postmenopausal women. The average age was 63 years old. And this trial was really created to answer the question, does hormone therapy prevent heart disease? And the reason why this trial was even created and funded by the NIH was because a lot of observational data up until this point had really looked very promising for hormone therapy and heart disease. So this trial randomized women to an estrogen arm. They got estrogen plus a progestin if they had a uterus, or if they didn't have a uterus, they would get estrogen alone or placebo. And so what they found was very surprising to them. Essentially, in the E+P trial, which is the estrogen plus progestin arm, women actually had increased risk for heart disease, so coronary heart disease, stroke, venous thromboembolism, which is basically lung clots and blood clots in your leg, and they had an increased risk for breast cancer. There was a decreased risk for osteoporotic fracture, and again, up until this point, a lot of observational data had showed that it could prevent osteoporosis, and also there was a decreased risk for colon cancer. And then in the estrogen-only arm, they found that there also was an increased risk for stroke, and a decreased risk for osteoporotic fracture. And interestingly, in the estrogen-only arm, they did not see an increased risk for breast cancer or coronary heart disease. So this was very confusing at the time. Once the trial results came out, hormone therapy prescriptions dropped dramatically. And at this time, the guidelines, which are put out by a lot of different organizations, ranging from the American Heart Association to endocrinologists and people who specialize in menopause, the guidelines are very consistent. Hormone therapy is not used to prevent any chronic disease, especially coronary heart disease. So that is very clear. And so I just wanted to, this is just to show you all the different organizations and how, and pretty much they all agree. So what conditions can hormone therapy be used for? So there are a few FDA-approved conditions. One of them is menopausal symptoms, and this is really referring to what we call vasomotor symptoms. These are hot flashes primarily, moderate to severe, that is not controlled with non-hormonal therapies. Also, vulvovaginal atrophy, which is a very severe form of vaginal dryness, where there's actually changes in the vaginal tissue. A lot of women will have very painful sexual intercourse, so it can be very life-altering. And also the third condition is prevention of postmenopausal osteoporosis. So just to go through the common menopause symptoms, which many of you may be familiar with: hot flashes, night sweats, sleep disturbance, irregular periods, a loss of libido, and vaginal dryness, as we talked about. And then in terms of osteoporosis, the other treatment that is FDA approved for menopausal hormone therapy, osteoporosis is a condition where you have thinning of your bones, and primarily this is diagnosed through a bone density scan, where we look at the density of your bone at your hip and also at your spine. Hormone therapy is not considered first-line therapy for prevention of osteoporosis, So we have a lot of non-hormone therapies like called bisphosphonates that work very well. So this is absolutely what should be tried first. And then for some women who cannot tolerate them or for some other reason it is not preventing osteoporosis, hormone therapy may be used. We estimate a woman's risk for osteoporosis using something called the FRAX calculator. It's FRAX. It's something that was developed by the WHO to look at a woman's 10-year probability of having an osteoporotic fracture. This takes into account your age, your gender, so it does males as well, family history, your use of steroids, so various other risk factors that can put someone at risk for osteoporosis. And just to go over some other prevention therapies for osteoporosis, for women who smoke, stop smoking, getting enough calcium and vitamin D, weight-bearing exercises, lifting weights, walking, that sort of thing, reducing alcohol. It's been shown that women who drink more than 3, or people who drink more than 3 glasses of alcohol per day are at risk, increased risk, and then really understanding what your risk factors are for osteoporosis. And then, of course, there are medications which we've talked about. And so who should consider or who can consider taking hormone therapy? And again, this is all evidence, this is all based on what the FDA has approved. It's women with severe menopausal symptoms, really menopausal symptoms that have altered their life, really made it, their quality of life has gone down because of their menopausal symptoms. Women early in the menopause transition, so this means women who are younger, and who have reached menopause within about 10 years, they're still within that window. And women in what we call good cardiovascular health. So these are women who really are at low risk of having cardiovascular disease, and you've heard some of the risk factors. Women who don't have cardiovascular disease. So this is really a small subset of women who we are not at all worried that they might be at risk or have cardiovascular disease. So those are women who could consider it. Women who shouldn't consider using menopausal hormone therapy are women who have a risk of having blood clots, either lung or lead clots, women with stroke. This is history of or risk for. So it's always important to understand that even if you don't have these things, if you are at risk for these things, menopausal hormone therapy is not something that should be considered. Stroke, heart disease, breast cancer, or liver impairment, because hormone therapy, at least the oral hormone therapy, is processed through the liver and can be changed if you have liver impairment. And so some other things that can happen should a woman decide to take more menopausal hormone therapy is that in the when they've looked at the WHI data, it turns out that 25% of women who stopped their menopausal hormone therapy abruptly, about a quarter of them ended up having vasomotor symptoms that return. And some of these women didn't even have vasomotor symptoms to begin with, so that might surprise you. You certainly don't want that coming on if you didn't have it before. The majority of women come off of their hormone therapy with no problems. Most women will come off within a year or 2 without even any help from their physicians. But this is something to keep in mind, is that menopausal symptoms will often go away after a few years on their own, even without any therapy. And even if you do take hormone therapy, symptoms can come back. It's recommended that if you are on hormone therapy that you taper it as opposed to abruptly stopping it. However, there's not a lot of evidence to show that this works any better, but it is the recommendation currently. And for any woman who comes off of hormone therapy, if her symptoms do come back, it's recommended that they at least have a trial of non-hormone options before they even consider returning to hormone therapy. And we'll talk about if hormone therapy is going to be initiated when. And what has happened since 2002 when the WHI results came out is there's been a lot of different analyses, and there's been additional small clinical trials looking at hormone therapy. And it looks like some of the association with hormone therapy and heart disease actually may be due to when it's given. So and this is known as the timing hypothesis. So this hypothesis is basically saying that if a woman is given hormone therapy close to when she had menopause or when she's young, perhaps the risk is low and the benefit is high or at least neutral. versus if a woman is given hormone therapy late, many years after menopause has started, or if she's older, the risks are actually higher and the benefit is low. So this, I'll just show you this timeline here. So this is the time point at which menopausal hormone therapy is initiated. So premenopause, menopausal transition, and postmenopause. And this is the ratio of benefits to risk. So let's just we'll just say here is where it's neutral, here is where there's more benefit than risk, and here's where there's more risk than benefit. So you can see that if you initiate, perhaps hormone therapy when someone is quite, very close to menopause, or right here, perhaps it's neutral, or maybe even early, a woman might get some benefit from it. As opposed to here, the older she gets, and age is a very big predictor of heart disease. So the older a woman gets and the farther away she gets from menopause, perhaps her risks are now higher with no benefit. And so that's really what this is called the timing hypothesis. And so let's just apply this timing hypothesis and try to explain, well, how is it that in the past, observational data really supported hormone therapy as being beneficial to heart disease, yet when they did the WHI trial, it was completely opposite. Let's try and explain that using the timing hypothesis. So what they're saying here is perhaps when a woman is younger and she has not developed any what we call fatty streaks in her arteries, versus when a woman is older and now plaque has actually grown and is much more likely to rupture. In observational studies, we normally recruit women who tend to be younger, while in the WHI, we actually recruited women who were older. The average age was 63, as you may recall. And so these women were well past the start of menopause. Perhaps because clinical trials tended to recruit women who are older, because we were looking for outcomes on heart disease. So you definitely want older women because they're much more likely to have heart disease. So it's possible that because that's the reason why we see this difference in observational data, it looked beneficial, while in clinical trials, it actually looked the opposite. Hormone therapy, when initiated when they're younger, it actually may have favorable lipid and endothelial effects, while when women are older, perhaps it's pro-thrombotic and pro-inflammatory, which means that it just causes more inflammation and makes them much more likely to clot whenever the hormone therapy is given when they're older. So I would say there's a lot of agreement now after new evidence has come out since the WHI data that for younger postmenopausal women, and younger is 50 to 59 or less than 10 years since menopause, that there is data to support that at least it's safe for these women if they choose to use menopausal hormone therapy. And again, this is a very small subset of women who we are not worried at all about blood clots, heart disease, that sort of thing. And the timing hypothesis has been supported by some recent data. There's something called, and this timing hypothesis really came about because of coronary artery calcium study from the WHI. When they did sub-analyses of the WHI data, they grouped women into age and looked at their risk, and meta-analysis from other smaller clinical trials. And then there was also a very recent trial that came out just the end of 2014 called the KEEPS trial, where they saw that there did not appear to be any increased risk for women who, it was a clinical trial that looked at women over 4 years who took transdermal estrogen versus oral estrogen and looked to see if there was an increased risk in heart disease, and they didn't find one over this short period of time, and these were young women who they enrolled in this trial. So in effect, just to kind of summarize that, starting menopausal hormone therapy close to menopause, using it only for a short period of time, and for the most part, 2-3 years at most, definitely less than 5 years, because again, the older women get, their risk for breast cancer increases, the risk for heart disease increases. So for women who do decide to take hormone therapy, is to have it be a short term, and then to monitor and have the physician monitor the hormone therapy frequently, at least 3 to 6 months, and for sure annually, and really trying to address coming off hormone therapy with women on a regular basis. And then how should hormone therapy be used, if it is used? There are many different estrogen preparations. There's oral, transdermal, and vaginal. And oral is just the pill. Transdermal comes in a lot of different ways. There's a patch, there's creams, there's gels, there's many different ways. And then there's vaginal estrogen, which comes in a ring or also gel, suppository. Oral estrogen looks like it has a much more favorable effect on the lipid profile. So it tends to lower the LDL, raise the HDL, but it has a less favorable effect on something called the C-reactive protein, which is an inflammatory protein, and it also tends to raise triglycerides. Oral estrogen looks like it increases your risk for stroke and blood clots. Transdermal looks more favorable. It does not have this, it doesn't have the favorable effects on your lipids, but it also does not seem to increase your risk for having stroke or blood clots. And then vaginal estrogen, the advantage of vaginal estrogen is for women who only have vaginal symptoms, using a low-dose vaginal estrogen can there's minimal systemic absorption. It treats the local problem, and also women do not have to add a progestin on top of that if they only use vaginal estrogen, unless they use a high-dose vaginal estrogen, in which case we do have to add progestin if you have a uterus. For both the oral and transdermal, if you're on estrogen and you actually have a uterus, we do have to add progestins to protect from endometrial cancer. So let's talk a little bit about non-estrogen therapies. The most common non-estrogen therapies are what we call the SSRIs and SNRIs. These are antidepressants. Most of the antidepressants that are used are off-label. Off-label means they're not FDA approved, but they do tend to work, so a lot of physicians do it. And actually a lot of off-label prescription it's very common for physicians to do this, but just to let you know, the only FDA approved antidepressant for menopausal hormone symptoms is paroxetine. And paroxetine specifically in the form of this thing called, this trade name Bristol. So Bristol is FDA approved in 2013 to be used for vasomotor symptoms. And other things that are used are anti-epileptic, so anti-seizure medicines. Most common one is gabapentin, also known as Neurontin. Centrally acting agents, this is clonidine, which acts centrally as in it acts in the brain, and so it sort of can, and it's used primarily as a blood pressure medicine, but it can reduce vasomotor symptoms. There was a meta-analysis, and a meta-analysis combines a lot of the findings from multiple different studies, combines them all together and sort of gives you a summary. So a meta-analysis of 43 different trials show that those non-estrogen therapies that I just listed are more effective than placebo. And it's important to remember that placebo, even with placebo, women will get an improvement in their vasomotor symptoms, but these therapies were still better than placebo. One antidepressant that I wanted to mention, which is not FDA approved, but has been shown in a very recent clinical trial to improve vasomotor symptoms, is something called venlafaxine, also known as Effexor. So there was a randomized controlled trial. It was just published in JAMA late last year. It looked at low-dose estradiol, which is an estrogen, versus venlafaxine, extended release, Effexor extended release, or placebo, so 3 arms. And they found that when women took estradiol, they had a reduction of 52.9% in their vasomotor symptoms. Venlafaxine, there was a reduction of 47.6% in their symptoms, and placebo was 28.6% in their symptoms. And so they found that there was no statistical difference between these two, which basically means that these two therapies were about equal in terms of improving women's symptoms. So that's a very I think this is really promising for a lot of women who do not want to take hormone therapy. There are therapies out there that can help you. Bioidenticals. So I just want to take a real quick survey. Have people heard of bioidenticals? Yes. Okay. Who in this audience believes bioidenticals are safer than commercially available hormone therapy? Oh, nobody. Okay. Wow, you guys are an educated group. Okay. So basically, I get this sense often when I have patients come to me on bioidenticals that my sense is that they believe it's safer than commercially available hormone therapy, and so that's why they choose bioidenticals. Bioidenticals, technically the term means it's a drug or molecular substance that is identical to the commercially available substance. But in the, I think in the lay public, what it's commonly been known is it's actually, instead of being just a molecular similar natural compound, it's actually something that is custom compound. And these are traditionally things that are supposedly dose adjusted based on your hormone levels. So oftentimes people get their saliva tested for certain hormones, and then a physician will then write you for a very customly compounded substance. And the problem with bioidenticals that I just really want to point out is that this is not FDA regulated at all. So this is an industry that's not regulated. And so it's really not been shown in any trials, in any studies, to be safer or more effective than commercially available therapies. So one of the things I do, for anyone who's more interested in reading about bioidenticals, there is something put out by the FDA called Bioidenticals Sorting Myths from Facts. And I found this very easy to read and very helpful, I think, for anyone who's curious about this. But like I said, there's no evidence that it's safer or more effective. So let's go back to our patient. I'm just curious, well, I'll tell you what we ended up doing, or what she ended up deciding to do, but does anyone believe that she should take hormone therapy, or is anyone here willing to put her, like if she came into your office, do you think she would be someone who you think, show of hand, would anyone? Yes, a few of you, okay, yeah. So she ended up starting hormone therapy. She took it for about she started a patch. She took it for a year. She actually tried to come off it on her own, and she did successfully, but her vasomotor symptoms, some of her vasomotor symptoms did come back instead of her vaginal dryness. So then she decided to use a non-hormone therapy, which is exactly what we would recommend for her. So she tried gabapentin, which is the anti-seizure medicine, and it ranges in dose, but anywhere from 300 to 900 before you go to bed. So she took that, and that really helped relieve her symptoms, and she's currently trying to wean off that as well. But this is really something that I think for a particular patient, it's a very personal decision as to what they want to do. Not only is it personal, but from a clinician standpoint, we really look at their risks and benefits before we recommend particular types of therapy. And if a woman is early in menopause, young, and has vasomotor symptoms, very severe ones that really affect her quality of life, hormone therapy is an option, and it looks like a safe option, but there are a lot of non-hormonal options that are also available. Thank you.
Okay, so I thought we'd start, there's a question about wine. I thought that was a good place to start. So someone asked, which is better for your heart, red wine or white wine, and then how much? And so basically, it looks like actually both red and white are probably equivalent. I think we think of red a lot more because there's been stuff about the antioxidants in it and resveratrol, but the data suggests that actually both of them can be good for your heart. It's all things in moderation when it comes to wine and alcohol. So there's kind of this curve, and it's called a J-shaped curve, and people that drink no alcohol, which are kind of on the upper part of the little J, actually have a slightly increased risk of heart disease. And then people who drink it in moderation, which I'll tell you what that is, have the lowest risk. And then people who start to drink beyond what's moderate, their risk goes way up. And that's the other end of the J-shaped curve. So moderate is, some people will be quite disappointed, but moderate for women is 1 glass or 1 serving, and for men it's 2. So a glass of alcohol is per day, yeah, not per hour or something like that. Yeah. So per day. So what? It's 4 ounces now. It keeps getting. Well, it used to be 6, and then it was 5. Okay, 4 ounces. Wow. Okay, even I'm disappointed. Okay, so that's the scoop on wine. So someone asked, what's the difference between a heart attack and an anxiety attack? And I wish our psychologist was here because she's fantastic at talking about that. She's actually on maternity leave. We've had an epidemic of pregnancy and women's heart health. But the symptoms can feel very similar, and so I think that's difficult for people. A heart attack is actually a problem that's going on in the heart, and an anxiety attack is actually kind of something that's going on in the head, but you get physical manifestations of that, and it can feel like a heart attack, that people will have chest pain, shortness of breath. It feels like the world's coming in on you, and you could have anxiety as well when you were having a heart attack. So I think for some people who have chronic anxiety, it can be hard to sort that out, which is one reason why we employ a psychologist to help us with that, because it can be hard for all of us in sorting out. It can be hard for physicians as well. In anxiety attacks, you actually don't have to be anxious, and I think that's something else we don't know. You're sitting there, and if you have anxiety disorder, you can suddenly have one of these attacks, and you weren't necessarily feeling anxious at all. So another test is, what test should a doctor order to detect heart disease in women? Do you want to answer that?
Sure. It depends on whether you're having symptoms or not. So if you're having symptoms, we would choose the appropriate test based on what the symptoms are. If you're completely asymptomatic, our guidelines are, again, you'll learn a little bit more about this in the prevention session, would recommend getting basic blood tests looking at risk factors for heart disease. And then there are some more advanced radiologic tests like coronary calcium scores or advanced lipid tests that we can do to further risk stratify you if needed.
Yeah, so there's not some magic test where you can come in and we'll say, oh, you're going to have a heart attack in the future or something like that. The tests really look at where you are in this day and age and at this moment, and don't necessarily predict what's going to happen. So like a stress test, you could actually pass and you could walk out and have a heart attack because something happened in the interim, because heart attacks can occur like that. We can't always just kind of figure it out that way. So a lot of it's about modifying risk. So let's see, someone asked, how would I know if I suffered a silent heart attack? And that can occur, right? I talked about all these symptoms, but you could actually have a silent heart attack. It's more common in people with diabetes that they don't seem to get the symptoms that we would expect. An echocardiogram or ultrasound of the heart would actually tell us that. An EKG could tell us that as well. So if you got an ultrasound of your heart, we would see that one part of your heart's not moving well, and that would mean that you had some sort of damage to that part of your heart at some point that you didn't even know that you had. The EKG will show the same thing. The EKG will change and show that one area of the heart is not pumping as well. So Sandra, how does menopause affect my heart health?
Oh, how does menopause itself affect your heart
Yeah.
health? It does look like age is a big risk factor for developing heart disease, and there's not a huge jump necessarily at menopause. So at that time, it's not, women do not all of a sudden increase in their risk. It's a gradual thing. However, what we commonly see in the menopause transition is a change in your hormones. I mean, change in your hormones, but also a change in your cholesterol. So normally a lot of women who have great looking cholesterol profiles, after menopause, their LDLs go up, their HDLs go down, their triglycerides go up. I think a lot of this is probably multifactorial too. For a lot of women, they start to gain weight. Maybe they eat the same amount, but they're maybe less active and they don't really need as much food. So there's a lot of different things that change during menopause. So in general, menopause itself is not necessarily a huge risk factor. It's mostly that after menopause, there is a change in many different things, and there is an increase because of your cardiovascular risk in general.
Okay, another question is, if I had a heart attack and I continue to smoke, will it raise my risk for a second heart attack? Yes. Okay. Next question. How many Tums can I take a day without getting calcium buildup in the heart? So this actually is talking about calcium supplementation, which I think has been an interesting topic because there have been a lot of studies that came out pretty recently about calcium supplementation and actually being associated with heart disease risk. And it used to be that we thought that how much calcium you ingested really didn't have an effect on calcium buildup in the arteries, but it turns out there actually may be a connection. And so calcium supplementation, at least from a cardiovascular perspective, is not recommended. I think it's on an individual basis. People take it for osteoporosis. Whether it has that much benefit that outweighs the risk from the calcium supplementation, I think is in question. At a minimum, we recommend that you really try to get your calcium through diet rather than through supplements if you can. So Dr. Khandelwal, can you talk to us briefly about murmurs? What is a murmur? And if you have some trace, what's called regurgitation or leakiness in your valve, does that mean that something bad's going to happen at some point?
So a murmur is something that we listen to with our stethoscopes on physical exam, and it's basically a disruption of flow or a change in pressure in the heart. So this can be caused for many reasons. Sometimes it happens that you have a murmur since birth and you will always have that murmur. Other times it can come and go based on the current state that you're in, whether you're dehydrated or not dehydrated. So if it's a murmur that is pathologic or something that you're born with, the murmur can be something that we can listen to on exam and follow over time to see if it's going to cause you a problem. And it's a surrogate marker for if the valve is getting more and more leaky or opening less well. In general, with our ultrasounds, we can look at the causes for these murmurs very well, and almost all of us have some trace physiologic regurgitation. It's built in to kind of wash the valve and keep it from getting blood clots on there. So for the majority of people who have trace regurgitation, there's nothing to really be concerned about. If there is an abnormality of the valve itself on the ultrasound, then over time we would watch it. But again, trace is most of the time it's just physiologic.
Great. And Sandra, what are your thoughts on the new guidelines for statin use after the age of 75? So you can maybe talk about the guidelines briefly and then how age affects that.
I love talking about cholesterol guidelines. Okay. The new guidelines came out in November of 2013, and they were very different than prior guidelines. 75 is one of the reasons why they have this at 75 years old, you can consider doing different things, is because the new guidelines are based a lot on randomized control trials, and a lot of the randomized control trial data was not collected in people older than 75. So we just don't know that much about people above 75. So that's the main reason. It is not so much that all of a sudden something changes about 75. It's because we don't have a lot of data. My recommendation normally to someone who's 75 and doing fine on their cholesterol medicine is not to change anything. I tend not to like to rock any boats. I think that if you are having problems, then I do think that there is justification to reduce your dose, change your medicine. I typically would not necessarily stop your statin because there's probably some reason someone has put you on it and you've been on it for quite some time. But I do think once the benefit-risk ratio tips to where the risk appears to be a little bit greater, you're having more problems with your statin than you are with the benefit, I think at that point it is an important thing to consider changing or altering your dose. So those are really the considerations. I do think that people who are a little older, we just don't know it. We just don't know as much, and so.
What are the problems that you're talking about?
The most common symptom that people have when they take statins are muscle aches. That's the most common, but even then, it's a small percentage of people. It's probably in the range of 5%, maybe less, something around there. That's the most common problem. Even people worry a lot about having liver damage because of statins. That is extremely rare. And even when people do have problems with their statins, all the problems are completely reversible when you stop the statin.
So I'm going to do the final question, which is what is being done to create parity of research funding for heart disease in women? I think this is a very important question. The research that we do dictates our guidelines and it dictates our therapies. And to date, more research has been done on men than on women. And so most of our treatments and guidelines are really based on men and how we can make them better. And that's a difficulty if we can make them better, yeah. And it's creating this gap that I showed you, right? So if we don't have the data on women, then we're not going to be treating them appropriately. So the NIH actually many years ago said, investigators need to enroll women at the same rate as men into trials. But unfortunately, this didn't really translate into action. They didn't have any way of enforcing this. And so men continue to be enrolled more often. I think there are increased efforts to put money into this. Research costs money. The AHA actually just announced one of its big grants that it's going to do this year, and it's on women's heart health. So we're very pleased about that. Actually, Stanford will be applying. We hope to get a grant like that. There's also individual fundraising that goes on. We actually go out into the community and find people that can help support the research that we need to do, because it can be hard to get it from federal sources, and that's getting increasingly difficult. And then we also encourage our women patients to get into research studies. So if you're in a position where you might be able to enroll in one, then take advantage of that, because you'll be helping other women when you do that. So these were fantastic questions. You've been a great group, and we've had a real good time talking with all of you. And again, we'll be available for more questions if you have them. Thank you so much.